to debate on definitive chemoradiation. I started off, I opened Devita and then did some PubMed search, looked up Perez. But then when I was told that I'll be debating Dr. Sabita, I also bought this book, How to Win an Argument with a Woman, and then started off. The overview of the talk is, historically, we'll look at historical evidence, randomized evidence, meta-analysis, some response evaluation that Dr. Kundan has already spoken about, some ongoing trials, and then conclude. So based on historical evidence, we have two good points, which principally hasn't changed over several years. From the RTOG trial, we know that dose escalation beyond 50 gray is not useful. And then based on the intergroup trial, we know that adding concurrent chemotherapy to radiation definitely adds benefit in definitive chemoradiation setting. There have been several retrospective analysis, observational studies that have published patients who have gone on observation after chemoradiation and have found that the outcomes are pretty similar. But then the one that is very important to us is, one that is important to us is the Italian trial, which actually gave us the answer that after a clinical complete response to neoadjuvant chemoradiation, especially with cis-5FU and RT, we could possibly be delaying surgery and using a surgery at a salvage setting whenever a patient gets a recurrence. So this is one of those important papers. Let's look at some randomized evidence that we have. The first trial would be the German trial, which started off with neoadjuvant chemotherapy using cis-etoposide and 5FU. And then for those who responded, they randomized to using surgery or to consolidating with additional dose of radiation, escalating a subgroup to 60 gray, leaving some with just 50 gray. And those who were at 50 gray, they were given hyperfractionated external boost. And those who went on to have 60 gray did receive brachytherapy also. So let's see what the results are. The results are pretty much similar. So patients who actually responded to chemotherapy, whether you go ahead with surgery or keep them on a chemoradiation arm, the outcomes are pretty much similar. So what they concluded is that those who are responders to induction chemotherapy would probably just benefit with chemoradiation alone. We'll move on to the next important trial, the French trial, which actually did a slightly different form of radiation. They did a split course radiation on one of the arms and standard 40 gray radiation another, and gave cisplatin 5FU on weeks 1 and 3. And then at the end of the initial chemoradiation, they randomized to either surgery or going on with a radiation boost. They found that this is a very good trial with fairly good number of patients on each arm. What we should notice is that people on the chemoradiation, about 96% completed the planned therapy, whereas only 85% in the surgical arm could complete. And then at the end of the results are that the outcomes are pretty much similar. So the data actually suggests that in squamous cell carcinomas of esophagus, even if they are locally advanced, patients who are responders to chemoradiation can be, can be observed with just chemoradiation, and surgery can be omitted and doesn't add much benefit. So we have some downsides on just leaving them with chemoradiation. One of it is that patients required a lot of palliative interventions for dysphagia later in the course. Another thing is that people during their last follow-up prior to death, dysphagia rates were higher in the chemoradiation arm, and also local regional recurrence probability is higher with just chemoradiation if you avoid surgery. Okay. So what if we are to look at Asian data? We have this large Korean data where again they gave neoadjuvant chemotherapy with cis-capecitabine and then put them on 50.4 gray RT along with concurrent cisplatin and capecitabine. The patients who achieved clinical response were about 47.6%. So this actually identifies about 50% of those will probably not be benefiting from surgery and can just be observed after chemoradiation. So the conclusion here again is that close observation with salvage surgery might be a reasonable option. Now this raises a question. So somebody who develops a local recurrence, will we be able to salvage them? Yes, even in this trial, they actually salvaged about 8 of 11 patients with the salvage esophagectomy, and then the outcomes were pretty much similar and the complications weren't different. So we also have another multicenter propensity matched study which says that active surveillance with delayed surgery did not increase dissemination rates, so no increase in distant metastasis. So also the postoperative complications were not adversely affected in those who were undergoing salvage surgery. So there can be a very good number of patients, at least 50% of them, who can be spared of surgery. Coming on to some systematic reviews and meta-analysis, one of the large Cochrane analysis has been done, which also includes an Indian study, and this is 7 studies were included, of which 3 were randomized trials. Here, the results were like this. There was no statistically significant difference in terms of short-term mortality between the CTRT versus CTRT surgery arm. No long-term mortality noted. The graphs I've projected. Medium-term health quality parameters were pretty much the same in both. The proportion of patients having recurrence after 6 months were also similar. Long-term recurrence rates, that is the time to event, was also pretty much same in both the arms. And proportion of people having local recurrence was still good. So if you are giving good chemoradiation and patient goes on a complete response, you could possibly just observe them. Coming on to another systematic review from Korea, the same team that actually did the randomized trial esophagus. We have 3 different answers. So the DFS was not different. The overall survival is pretty much similar. That is, the long-term outcomes are quite okay. But then one thing that is the downside of observation is that there were a lot of loco-regional recurrences that required salvage or further treatment. Okay, let us also look at one of the guidelines, the ASCO guidelines. The ASCO guidelines does not suggest observation. It still prefers to do chemoradiation plus surgery in patients with advanced squamous cell carcinomas. But then definitive CTRT is definitely an option for those who are not fit for surgery, for those who choose not to undergo surgery and go on the observation arm. Well, we should also be discussing several other factors, especially in the Indian scenario, where shared decision making is important, considering age, comorbidities, the patient preference, etc. If we are talking about patient preference, let us see if we have data on patient preference. Yes, this is very large data from Netherlands, where patients were actually willing to forego or trade off the substantial benefit of surgery in terms of organ preservation. They would rather prefer to have their organ preserved rather than getting a little extra 5-year survival. So that's the patient preference article. So why are we actually trying to preserve the organ? Why do patients fear surgery and then walk out of doing surgery? Because when we put on the plate that the outcomes are going to be same for responders, they are actually worried about something, that's the complications. So complications, this is an article from India, from a tertiary center in India, where there could be respiratory complications, cardiothoracic complications, and others also. Then there are several other surgical complications in spite of using minimal access surgery, especially anastomotic leaks, hemorrhages, chylothorax, intestinal obstruction, and several others. So these are things that actually put off the patient. And we also see that on randomized trials, the complications rate immediately were 9% in the surgery arm versus just 1% in the chemoradiation arm. And also at 6 months, the rates were significantly higher in the surgical arm, with 16 versus 6% in the chemoradiation arm. Okay. On the Cochrane analysis also, the quality of life parameters are much better with the chemoradiation arm alone versus surgery. And also the short-term mortality is at 9% with the surgery versus 2% in the chemoradiation arm. Okay. So we are quite clear on one aspect, that the complications are definitely going to be higher, and the chemoradiation arm is actually favored in terms of reducing mortality and acute complications. So to consolidate whatever we've seen till now, what would somebody do for a patient with a midthoracic squamous cell carcinoma? We know that based on the time-tested trials, RTOG and the intergroup trial, the radiation dose is going to be anywhere between 45 and 50.4. Chemotherapy, we have a slight shift after the cross trial. A very well tolerated regimen, the carbopacli weekly, I think should be the drugs of choice. So do we have Indian data for using carboplatin and RT? Yes, we have Tata data of about 179 patients, and they've shown a clinical complete response of 49%. We also have AIMS data from India, where they've actually shown a 80% clinical complete response. Okay, so how are we going to response evaluate these patients after giving chemoradiation? Dr. Kundan has actually made the job easy. There is no one single solution for evaluating a patient after concurrent chemoradiation. It's going to be a combo of tests that we may have to do. That's a little cumbersome in the sense, definitely patients have to undergo upper GI endoscopy, plus or minus an EUS FNE of the suspicious nodes, and plus a 3-dimensional imaging, preferably PET CT scan. So it's going to be a combination of 3 that is actually going to response evaluate, and not one single technique. So what we'll probably be taking off from this pre-SANO is that this combination would be the best. So how is the SANO trial designed, the results of which is awaited? OGD scopy at 6 to 8 weeks, and then 8 random biopsies, 4 of which would be bite-on-bite biopsies to be more specific. And if that is negative, go on to do a PET scan to see if there is a metabolic response or there is no destined metastasis. Same patient who is on observation will go on another round of such tests, first with a PET scan, and then if the PET is negative, we'll again go on to have OGD scopy and biopsy. So this is what probably we should all be doing, quite an intense protocol. Well, what are the ongoing trials? The ongoing trials, the SANO, the celiac, and possibly the ESO-straight will all give us answers. These are actually nowadays using carboplatin and paclitaxel. We also have an equivalent Chinese trial called the pre-SINO and the SINO trials that will give us answers soon. So in conclusion, in a patient who achieves a complete response after chemoradiation in a midthoracic squamous cell, they should not be offered surgery. Thank you for patient listening.
Thank you, Dr.
All the organizers, especially the team at HCG, for having me here. I'm really shocked. In spite of being the minority person here, I think maybe one of 5 women in the room, people had to buy books on how to win arguments against me. So I'm shocked by the image that I have created, or the people that have created. I'm not so terrible, I assure you. So let's get on with this debate. And actually, I don't think there is any merit to the debate, but since I was asked to do this, I'm going to go ahead and show you how my esteemed colleague is very, very far from reality. So let's start off. Middle third squamous cell esophageal cancer is still, can I move the slides from here, or they are going to move it? Okay. So when we look at the 8 standardized ratios of esophageal cancer, in India is not a country where this disease can be ignored. It is the 6th most common cancer in our country. And even though the West is moving towards adenocarcinoma, we are still having a high burden of squamous cell carcinomas. Earlier, it was 95%. Now we are still at 90%. So 90% of our disease is still squamous cell carcinoma of the esophagus, and most of them are middle third. So what are the unique features of middle third esophageal cancers? 95% are squamous cell, like I already said. They are very close to the airway, to the tracheobronchial tree, to the carina, to both the major bronchi. So this will affect your treatment decision. I'm sure all of you attended the panel by Dr. Sanjay Sharma, and he showed us the first case which had a paratracheal node. Now these will be much, much more common in middle third cancers, in squamous cell cancers. So the chances of fistulation with radiation should be kept in mind, and that's why for staging we will always do a bronchoscopy for middle third esophageal cancers. And if you have the slightest doubt, then neoadjuvant chemoradiation will also not be preferred. Forget definitive chemoradiation. Surgery in these cases is likely to be extensive. Most of them will require a 3-field, and the extent of nodal metastasis is something which is going to make delivery of radiation quite difficult. Like Sir said, the nodal involvement, if it is far away from the primary, how much radiation are you going to give? What are your portals going to be like? So in a middle third squamous carcinoma, as you can see by this figure, 20% of them will have nodes in the neck. Almost equivalent will have nodes in the abdomen. Are you going to cover the entire field with radiation? I think neoadjuvant is difficult enough. Definitive will be a challenge for most radiation oncologists here. So what does the guideline say? This is the latest guideline from NCCN, and ASCO also supports it similarly. Only for cervical esophagus or patients who are not willing for surgery is definitive chemoradiation the standard of care now. Otherwise, we would always prefer pre-operative chemoradiation. But in our setting, where we see the burden of squamous cell carcinomas in the middle third, we sometimes have to resort only to chemotherapy because the nodal burden and the extent of disease is too high. So how did this debate all come into being? First of all, this was the largest meta-analysis which was published in 2011 by Soquist, who looked at 24 trials and said that the outcomes with neoadjuvant chemoradiation and surgery are preferable to surgery alone. And the hazard ratio for squamous carcinoma was 0.80, which was quite good, and it gave us a solid ground to start, giving neoadjuvant chemoradiation to most of our patients. And we saw that this was fueled by the pathological complete response, which was anywhere from 15 to 30% in most of these studies. But this came at a price. Like Dr. Madhu said, there are complications when you add surgery to chemoradiation. So the pathological complete response, the good survival, does not come without a risk. And the risk is the postoperative complications that we see in this case. Then came the landmark paper, the cross trial, which swayed the entire world. I mean, especially Europe and also in India, where more and more people started thinking of giving neoadjuvant chemoradiation to try and achieve these kind of median overall and 5-year survivals. And the pathological complete response was a stunning 59%. So half the patients got a pathological complete response in this trial. And why did it have such an impact? It answered a relevant question: what neoadjuvant therapy to use? It was contemporary radiotherapy, all the toxicity was well documented, and the chemotherapy was something where surgeons, radiation oncologists, and medical oncologists all were comfortable with. So it had good compliance, it was a multi-centric study. But there were some caveats. The median length of the tumor was 4 centimeters. The median length of the tumor that we see at Tata Memorial is 7 centimeters. Most of the tumors were distal third and esophagogastric junction. 31% margin positivity rate. Inclusion of patients who were only PS 0 and 1. Most of the patients were around 60 years of age. Only 23% were squamous cell carcinomas. There was no comparison with neoadjuvant chemotherapy as a standard arm, whereas the previous meta-analysis had already demonstrated that chemotherapy also has a survival benefit. It's not like it is without a survival benefit. And real-world data and other studies showed that there was more morbidity after neoadjuvant chemoradiation, whereas the survival was similar when you give only neoadjuvant chemotherapy too. So the Chinese obviously copied the trial, got better results, and they expected the world to believe it. So this begged the question, can we avoid surgery? Is organ preservation possible? Now these are the two trials my colleague referred to. The STAL trial published in 2005 and the FFCD, which both showed that there is no benefit of adding surgery when you give neoadjuvant chemoradiation. But when you look at these studies, look at the median overall survival: 16 months, 15 months, 19 months. Very low compared to the current survivals that we see. Minimally invasive surgery was not used in any of these studies. And although the progression-free survival was higher in the surgery group, this was offset by 10% mortality rate. Now, in any institute of any repute or standing, 10% mortality is not what we see or expect with the esophagectomy. Mortality is way below 5%, even in not in a tertiary center, even in small centers in small towns. So the surgery has been standardized. Most of us have moved to minimally invasive surgery, and this is not the real world data as of now. So they came along and started doing meta-analysis, because when you don't have a definite answer, what do? You do meta-analysis. So you look at this one by Kransfelder. They said definitive CTRT can be an alternative to trimodality, and the morbidity, when you see in the first figure, is quite high when you add surgery, and the mortality is also high. So, trimodality may have a higher R0 definite evaluation, but it is associated with long-term survival, but definitive CTRT can be an alternative option. When you look at it closely, this is the analysis which actually changed the game. Podgen meta-analysis published from Germany, and this fueled the pre-SANO and the SANO trials. And what they said, that the hazard ratio was equivalent. It was 0.98, quite tantalizing. It is, just absolutely the same. There is no difference whether you give only chemoradiation or you add surgery. Now, when we look closely at this, there were only 6 randomized control trials in this meta-analysis, out of which 2 were published only as abstract, and the total meta-analysis had led less than 1,000 patients. So they said there was trend for more cancer-related deaths in the definitive CTRT arm. The hazard ratio was 1.19, predominantly due to higher risk of loco-regional progression. But can we change practice based on this data, which is less than 1,000 patients, and of which there are very, very small randomized control trials, and 2 of them are not even published as full papers. So do we trust this data? Then another meta-analysis by Ma, which looked at only Asian patients, and they concluded definitive chemoradiation and surgery are equally effective as initial treatments, note the word initial, for potentially resectable esophageal cancer, and these results apply to Asian populations who have increased incidence of squamous cell carcinoma. Again, this is published in 2018, the most recent one that I could find. 13 studies, 2,000 patients. Most of the data was from Japan. 34% of the patient had stage 1 disease. Stage 1 disease does not require multimodality therapy. They will do anyway very well with single modality. So why were these patients subjected to multimodality therapy? And again, only 2 randomized control trials, which consisted of 359 patients. So definitely, I do not agree with this conclusion, and I'm sure most of the audience in this hall also will not agree. So they kept looking at breaking down the data, looking at the morbidity, mortality, and they kept finding the diamond in the forest plot with a hazard ratio of similar to definitive chemoradiation, and they concluded that it's okay, we can just give definitive chemoradiation. And this was what was happening in the Western cohort, similar to the Asian, but they said that patients who undergo only definitive chemoradiation do worse than those who undergo only who undergo trimodality therapy. So in the meanwhile, while the radiation oncologists were doing one meta-analysis after another and trying to break the data and see how they can, avoid surgery, surgery was becoming better and safer. Minimally invasive surgery proved its mettle in the TIME trial as well as the MERO trial. And when we looked at the mortality in the trials which had incorporated trimodality, you can see the 30-day mortality was as low as 3 and 2% in the cross trial, and in Neocritic it was even lower. So there came the pre-Sano trial, 207 patients from 6 high-volume Dutch centers to detect the accuracy of detection methods to see if they can adequately predict which patients can be observed and which patients should undergo surgery. They used the cross regimen because it's very popular in Europe. They changed the protocol midway. So the initial protocol was only endoscopy and biopsy. Later on, they changed it because they saw that they were missing quite a few patients, and they changed it to bite by bite. Now, when you look at the published pre-Sano results, this is what they saw. 1/3 of the patients with TRG 3 or 4, that is 31%, were missed with regular endoscopy. 10% of the patients were still missed when they did bite-on-bite biopsy. And EUS missed TRG 3 and 4 residual tumors, again in 30% of the patients. So can we actually apply these protocols and safely sleep at night and think, okay, I am going to observe this patient and I am not going to offer surgery? Sano has been designed in a similar way, where they are doing a clinical response evaluation 2 times, at 4 to 6 weeks and then at 10 to 14 weeks. Those patients who have locoregional disease only at the second evaluation will undergo surgery. They are looking at OS, DFS, quality of life, and as well as cost effectiveness. Other trials are also coming up in Europe. NEEDS trial, Tata Memorial Hospital is a part of this study. The ESOTRACE has actually said that surgery is superior, and they are determined to get a 15% difference in disease-free survival. So this trial will actually come out in the next 1 or 2 years, and we'll see. So what are the issues? Why are surgeons against stopping only at neoadjuvant chemoradiation or giving definitive chemoradiotherapy to these patients with middle third squamous carcinoma? The tools that we have to detect pathological complete response, are they foolproof? Are you happy leaving a patient with EUS, endoscopy, PET CT, and definite 100% that this patient does not have disease? I can keep this patient on surveillance. As the previous speakers before me have said, that this response is not only determined by the tumor. There are molecular markers, there are genetic markers which determine response. How do we surveil these patients? How do we ensure that the patients are compliant? They'll come to you for the first follow-up, the second follow-up, but these patients have to be kept under surveillance for 5 whole years. How do you do that? Do the patients understand the risk with delayed surgery, with salvage esophagectomy? It is far riskier than an upfront esophagectomy. And is salvage esophagectomy something that any esophageal surgeon or any general surgeon can perform with confidence? And has pathological complete response ever proven to be a surrogate survival marker in any other cancer? I don't think so. So these are some of the studies. This was published by the pre-Sano study group, where they said when you have to predict TRG3 and 4 versus TRG1 and 2, the sensitivity and specificity is in the range of 50 to 70%. So they themselves have said that after 12-week mark, it is not accurate. PET-CT is not accurate to follow up these patients. A meta-analysis on endoscopy and EUS and biopsies has said that these modalities cannot be used to withhold surgical management. Is salvage esophagectomy really safe? The mortality may be similar in high tertiary volume centers, but what about the morbidity? 3 times of the anastomotic leaks, twice the number of pulmonary complications, increased chances of positive margins. Again, similar results from all around the world. So what is the way forward? Definitely we have to think of organ preservation, of preserving the esophagus in patients where we can. But as of now, I don't think we have the tools, we don't have the protocols. These protocols have to be determined not only by the tumor and the patient characteristics, but also by the expertise that is available. So this is the ongoing research, patient perspectives on repeated imaging and repeated biopsies when they are under surveillance. Preoperative, if we can do away with endoscopy and detect the response only on imaging, and if there are any nomograms, we can come up to risk stratify the patients. Already, checkmate has been spoken about, where the patients without any response can undergo immunotherapy and still achieve a good survival. So, do significant number of patients achieve PAT-CR with neoadjuvant chemoradiation? A resounding yes. Is neoadjuvant therapy plus surgery the most effective strategy? Yes. Is definitive chemoradiation equivalent to trimodality? Not proven. Can we replace trimodality with definitive CTRT? Not yet. And is there a role for organ preservation in esophageal squamous carcinoma? Selective role. Patients with comorbid conditions, patients who are not willing for surgery, or where the expertise is not available. Otherwise, I think trimodality is here to stay, and it is safe with the current kind of surgery that we can offer now. And
They've improved. Most of the trials that were done in the past used 2D radiation techniques and gave very wide margins and single fields, whereas the radiation techniques have improved much more. If we were using IMRT or any other higher technique, we could probably be using split fields in patients who are having nodes that are far away. You don't have to be using single large fields to cover patients.
yeah, but we need that expertise available everywhere, don't we?
Same applies to surgery
Yes,
also.
it does.
There's
I
not a
agree
robot
it
sitting
does,
in every
but
town in
we
India.
can't do away with surgery as of now. I don't think so.
No. Then you have, thanks for the last slide. There is a selective role of patients who for patients who can actually avoid surgery. Those who undergo complete response, at least on the imaging that is available currently, PET-CT and endoscopy, we can, I think, safely put them on. And to answer the response evaluation, MRA is coming up in a big way with diffusion restriction. At least in centers that it's available, we should probably be using all 3 techniques, endoscopy, PET and MRI to response evaluate. Thank you.
I think we are still 5 to 10 years off from adopting this strategy. I don't know how many patients will follow up so frequently and undergo so many investigations. Thank you.